చెప్పినాక అక్కడ బాగా
అప్పుడే
చెప్పన్నారు కదా.
పెట్టాడేంటి?
ఏంటి?
అప్పుడే లైవ్ స్ట్రీమ్ పెట్టాడేంటి? స్టార్ట్ అయినప్పుడు పెట్టమని చెప్తే బాగుంటుంది కదా.
అవును, రికార్డింగ్ మనం స్టార్ట్ అయిన తర్వాత రికార్డింగ్ స్టార్ట్ చేయాలి.
అదైతే చెప్పాలి, ఎందుకంటే మన ఇవన్నీ కూడా యూట్యూబ్ లో వస్తాయి.
అందుకని అన్నసరి మాట్లాడకుండా ఆయన ఇచ్చేస్తాయి. సార్ రాలేదేంటి, ఉన్నారు అక్కడ?
వస్తారు, ఇంకా నేను బయలుదేరుతున్నాను.
బయలుదేరటం కాదు, 8 కదా, ఇంకా ఆన్ చేయలేదంట.
అదే అదే.
Good morning, sir. Satish sir, David sir.
అన్నా గుడ్ మార్నింగ్ అన్నా.
సార్ గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్.
శ్రీనివాస్ సార్, మీ క్లాస్ అయ్యాక మాట్లాడతాం సార్. నేను సారీ మాట్లాడలేకపోయాను.
ఏంటన్నా స్పీకర్ రాలేదు ఇంకా?
గుడ్ మార్నింగ్ సతీష్ గారు.
సార్ గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్ శ్రీను.
ఏంటన్నా స్పీకర్ ఇంకా ప్రిపేర్ అవుతున్నారా లాస్ట్ మినిట్ లో?
Good morning, sir.
గుడ్ మార్నింగ్ సార్.
Sorry, కొంచెం నెట్ కనెక్షన్ ఏదో సడన్ గా నెట్ కనెక్ట్ అవ్వలేదు సార్, లేట్ అయింది, సారీ.
సార్ గుడ్ మార్నింగ్. ఏంటి
డేవిడ్ సార్, సారీ, జస్ట్ 2 minutes లేట్ అయింది సార్.
పర్లేదు సార్. గుడ్ ఏంటి మా చుట్టూ ఏంటి డిజైన్ వచ్చింది?
ఏమో సార్, పాత దాంట్లో అలా ఉన్నట్టుంది, అది వచ్చేసింది ఐఏసీసీ ఏదో.
రేపటికి ప్రిపరేషనా సార్?
అదే
రేపటికి కరెక్ట్ గా సరిపోతుంది సార్. అది బ్యాక్గ్రౌండ్
అదే మామూలు జూమ్ కి వస్తుంది, రొటీన్ కి రాదు.
సార్
కరెక్ట్, బాగుంది సార్, బాగుంది ఇది.
సార్
షేర్ చేయండి సార్.
సార్ చేస్తున్నాను సార్.
షేర్ చేసి షేక్ చేయండి సార్.
వచ్చిందా సార్?
వచ్చింది సార్.
ఫుల్ స్క్రీన్ వచ్చిందా సార్?
ఫుల్ రాలేదు, ఇంక పెట్టండి అది.
సార్
స్లైడ్స్ ఓకే సార్.
ఫుల్ స్క్రీన్ వచ్చిందా సార్?
వచ్చింది.
రైట్,
స్టార్ట్.
షల్ ఐ స్టార్ట్?
Good morning all. Today Dr. Mohan Maharaj is going to talk on heart-lung interaction in a ventilated patient. This heart-lung interaction is one of the complication, or it is the either deleterious or beneficial effect by the mechanical ventilation. So Dr. Mohan Maharaj sir is the director and head of the department of critical care Medicover Hospitals. He is going to enlighten on heart-lung interactions in mechanically ventilated patients. Thank you, sir. Please start the presentation.
Yeah. Thank you, sir. Thank you for the conclusion points of the talk with simplification. It's actually a 20 minutes talk. I think today I'm going to take almost maybe 40 minutes, depends on the slides. And first of all, at the outset, there's a disclaimer that I would like to thank Dr. Sharada and Varalakshmi for making me this preparation. And coming to the heart-lung interactions, this is one of the first studied and understood by critical care specialists and as a physicians or physiologist, the importance of heart-lung interaction, because nowadays the organ crosstalk is going on and everybody knows about it. In that, the first organ crosstalk between the two vital organs of lung and heart has been studied well and very clearly understood by now. I think, as David said, it's going to be useful for some and deleterious for some people or normal patients. As usual, respiration is a involuntary, and with inspiration is active and expiration is passive. But if you see from the history, almost long back in 1733 itself, so the Stephen Hales studied in mares, that is adult female horses, where they kept the live tubes in the vascular system and studied the difference between the vascular pressures in changing with the respiration. So from that time we understood, but over a period of time, by 1956, Cornard got a Nobel Prize because he has been studied extensively and made the types of positive pressure breathing and above atmospheric and either in the expiratory and continuously through the respiratory cycle or intermittent, which actually intermittent circulation is better. So this has been studied with the heart catheterizations, which we started from the cardiac surgery time onwards, where we could able to understand more the pathological changes in the circulatory system. With that, we understood that the changes are there because of the pressure systems. And we all know that, and over a period of time, recently from 1961, I mean, it has been actually published in 1961 itself, saying that if you see the diagram here, so there is when there is expansion of the alveoli, this is called, the one lung unit you call. So there is a extra, I mean, there's a major vessels have been expanded with the expansion of alveoli, whereas a capillary interalveolar vasculature has been constricted and reduced the size and the volume. This is what the effects of different types of the single unit and the single lung pulmonary vasculature has been changed. So these are all the clearly understood mechanisms and effects of this been studied, and we know. So when it comes to the understanding of this lung heart lung interactions, we are going to talk about, as we all know, breathing or respiration is an exercise. So it requires blood flow, it requires oxygen while it is giving carbon dioxide, but it is an exercise. For that, that's we look into the work called as a work of breathing. What is a work of breathing? Goes to effect on this heart lung interaction, how the volumes are going to affect the heart lung interaction, and what is important of intrathoracic pressure. We understand these things by this talk. So as usual, so maybe a male represents bad and a female represents good. That doesn't matter. But issue is that for some patients, particularly we know like sleep apnea and particularly for LV failure, and even at the time of weaning, as you said, breathing is an exercise. It is going to be very good beneficial effect by the ventilator or supportive ventilation. Whereas when you are increasing the ventilation to the normally a breathing is a negative pressure increase in the intrathoracic pressure in a normal respiration, whereas in the positive pressure there's an increase in the thoracic pressure. So that will have a deleterious effect on the heart because it's a closed chamber of the thorax which is having a in vascular chambers inside the thorax. So if you see that here, the diagrammatic representation, there's a lung and heart in thoracic cavity. So that's the reason the pressure chamber within the pressure chamber, we call it as, and there is a pressure gradient, there's a reflection of pressure. But if it comes to the heart, the extra thoracic, that is a systemic, there's systemic blood coming into the heart and going into the systemic. So that's why the reflection of the pressures in the heart is going to reflect the systemic pressures and the intrathoracic pressures. So this is what change. Whereas if you're coming to the more compliant and pulmonary vascular, which is within the chamber, because coming from the heart to the lung, lung to the heart. That is why there's no much change in the pulmonary vascular system by the external pressures, because the heart is going to affect, and the intravascular, intrathoracic, the pressures are going to affect this systemic vascular, not the pulmonary vascular. So just another few points we can say that if you come to the understanding of venous circuit, normally we have a stressed volume and unstressed volume. 70% of the blood of the cardiac output, which is there, that is in the venous vasculature. That is called mean circulatory filling pressure, which is actually constant normally, unless it is been having more and more fluid or increasing the volume or increasing the vascular tone. So that circuit actually does not have, because if the veins have been collapsed till it gets filled, there's no change in the pressures. But once it gets filled and further volume is there, there's a increasing the pressures can happen. Right pressure. Anything, sir? So right atrial pressure leading to the right ventricular filling. So what I mean to say that if the atrial pressure is being there's right atrial pressure, which actually reduces, so that increases the venous return, which increase the RV filling. So the right atrial pressure minus the intrathoracic pressure is RV filling. And if it comes to arterial circuit, which is actually left ventricular into the arterial tree, which gives, so that is what is the arterial circuit. So left ventricular ejection pressure, that is called arterial pressure, that is arterial pressure minus intrathoracic pressure is a left ventricular ejection pressure. So these are the pressures which we need to understand. So difference between the inside and outside, that's called transmural pressure of LV and transmural pressure of the RA. So these are going to change, and that will change as per the intrathoracic pressure changes. So this is what happens in the venous system. And now coming to the how it is going to affect from the RA to the RV. So what effect is going to happen to the intrathoracic pressure by the respiration when you are giving inspiration and when you are expiration. So when you are inspiration, there is a increase in the intrathoracic pressure, and the intrathoracic pressure, when it happens, there is a almost the reduction of the RA pressures, So in the same way here, the right ventricle gradient for venous return. So that is nothing but transpulmonary pressure minus systemic filling pressure. So what happens actually, there is if the patient is taking a respiration, if the normal respiration is okay, but otherwise, if there is airway resistance is increased or airway pressure is increased, and there is a decrease in venous return, and at the same time, when there is a decrease in venous return, there is a decrease in RV preload. So automatically, the right ventricle end diastolic volume is reduced. When the right ventricle end diastolic volume is reduced, and automatically there is reduction of stroke volume, and at the same time, when the pulmonary vasculature and lung is normal, so it is almost equivalent to the cardiac output. So there's a direct reduction of stroke volume and cardiac output. So the compression of the heart by the lungs in the cardiac fossa decrease the cardiac output because there is like cardiac tamponade effect. And the raise in the pulmonary vascular resistance, which because of the volume, when you have the taking the respiration inside, so that will increase the RV afterload. So that means after output is reduced. When there is an increase in the RV afterload, the RV output is reduced, and at the same time, stroke volume is reduced. So again, look at it. There's if you look at the RV contractile reserve, which is less than LV contractile reserve, because it is a big musculature, whereas RV have a good compliant lung, so that means easy to push the lung. Most of the times, RV volume is almost like you are having into the volume of the unstressed volume, or RV end diastolic pressure is almost like by itself. It is not much of any external factors. So volume is by itself, it can go. That is the reason the ITP, that's intrathoracic pressure swings and afterload during the respiratory cycle have a greater effect on the RV than the LV, because it can pump better even there's a little increase in the afterload or pressure in the LV. But whereas RV cannot do that much because of this muscularity and because of this pressures. So this is actually just a small 2 minutes video saying that. So this is how the blood is being flowed from the normally there is a very less resistance flow system, which is like a muscles. There's no much of rhythm, and actually depends on the gradient of the vessel pressure, because pressure gradient of the venous pressure and the radial pressure is only 4 to 10. So even that 4 to 10 pressure difference which is sufficient to draw the venous return. But whereas artery, it requires minimum of 10 to 40 mmHg. So that is the difference between the atrial, the gradient pressures, and the venous gradient pressures. So that's called thoracic pump. So when they have taking a good inspiration, so intrathoracic pressure automatically, which will have reduction. At the same time, there is because of reduction of thoracic pressures and in the inspiration, that will cause this heart compression, reduce the right atrial pressure. So that actually increase the venous return. So at the same time, when you have taken a Duke inspiration, this will become straight and diaphragmatic. That's why increasing the intra-abdominal pressure. When the intra-abdominal pressure is increased, the venous return again, because of that, it will actually decrease the thoracic pressure. So again, so there is a increasing of the fluid into the right atrium. So that will increase the actually venous return. But at the same time, thoracic pressure, the stroke volume, because of the compression, there is a reduction of stroke volume, but the pulmonary vasculature has been increased. And in expiration, increase in thoracic pressure, reduction of venous return. So that will cause the left atrium fissure comes, stroke volume increases at the result. So, but overall, in a normal respiration, normal people, inspiration, expiration, unless it is having a pathology or having a high forced expiration, it will compensate the total cardiac output. So normally, if you look at the venous return, which is a constant. So when you have a spontaneous respiration and you have a positive pressure ventilation, mechanical ventilation, if it is an apnea, there is a constant venous return which is there, and there is a in spontaneous, there is an increase of the intrathoracic pressure and reduction of, reduction of the right atrial pressure, which will actually affect the LV function. That is what is the cardiac output, which actually increases. And when there is a mechanical positive breath, there is a reduction of the cardiac output because there is an increase in the ITP and increase in the right atrial pressure, which reduce the cardiac output. This is what happens in a graphical manner. So what happens? This is a normal respiration. This is a mechanical respiration. During negative pressure respiration, that is a normal respiration. When you inspire a good volume or lung expansion, there is a decreasing in the pleural pressure and increasing in the transmural pressure, which actually have the effect on the ejection fraction and which increase the LV afterload. So that again, which actually increase in end diastolic end left ventricular end systolic volume. Left ventricular end systolic volume. So automatically, because of this, there's a reduction of the cardiac output. And when you have a forced expiration, because this is inspiration, this is expiration, there is an increase in the intrathoracic pressure and pleural pressure, which decrease the transmural pressure. Again, decreasing the afterload will have a better outcome and good pressure, and LV and systolic volume and the same arterial pressure increases. This is what cardiac output increases in expiration. When you have a positive pressure ventilation, when high PEEP or large tidal volume are employed, so there is when you're increasing the pleural pressure at the time of inspiration, so here is a decreasing, and there is a decrease in transmural pressure. So which actually decrease the LV afterload. So that will increase the ejection arterial pressure also increases. So this is what is a difference between in the inspiration of mechanical ventilation and normal respiration. So what is the effect of this on the left ventricle? So if normally, as we told, this is the normal patients, but in case there is a LV dysfunction, and which is actually sensitive to afterload changes more, because that depends more on the afterload. As we told, normal breathing, normal heart function, normal LV function, there is no much, and the little bit of increasing afterload can be taken by the LV. But whereas LV dysfunction, which he can take, the contractile LV cannot take that much, so it is sensitive, depends on the change of the afterload. So when you put a PEEP on these patients, there is a decrease in transmural aortic pressure. There is a decrease in the transmural aortic pressure. So that decrease in the afterload. So that will increase the cardiac output. That's why there is a better effect on the PEEP. Not very high PEEP, but the PEEP. So coming to this, even if you see the physiology, I understand we ourselves, when there is a lung is in stretched because of the volume, there is a stimulation of stretch receptors, which actually increase vagal nerve afferent and different activity, which depress biventricular function and lowers pulmonary vasoresistance during increments of the PEEP. So what we call it as this, humoral effects of this prostacyclin related humoral effects, which comes in later. So what happens to now we understood about the breathing and work of breathing, effects of that. Now what will happen, the effect of the volume of the lung. What will happen to the autonomic tone, what will happen to the sinus arrhythmia and parasympathetic withdrawal. Sympathetic withdrawal depends on the volume of the lung we are giving and what affects on the pulmonary vasoresistance and heart-lung interactions, what will happen. So this is what happens normally when there is we all know that respiratory sinus arrhythmia occurs because of the cardiac acceleration during the inspiration implies a normal autonomic function, which is normal. So this is sinus arrhythmia that is little bradycardia at the time of when you're taking the respiration, that is a respiratory cycle. So why, when there is a large tidal volume and there is a inflation of the lung, when there is inflation of the lung, there is a dilatation reflex, which actually can cause compression of the heart. So there is a cardiac depression can occur because it's a compressing, because the same chamber, there is no, the space is the same. So this is actually also it can have again the prostacyclin induced humoral mediated effect can occur. So at that time, when the mechanical ventilation, positive pressure ventilation is happening, there is increasing intrathoracic pressure, there is a decreasing heart rate and decreasing stroke volume, which can affect hemodynamic alterations. And because of autonomic nervous control, there is an increasing in heart failure or decreasing lung volume of this one. The difference between the lung and heart volume will be changed. So there is effect of this dilation and autonomic dysfunction can occur. What will happen to the pulmonary vascular resistance? We all know as if you call it as anesthesiologist or intensivist, hypoxia constriction, why it happens. And at the same time, when there is a hypoxia, when there is a change in the oxygen requirement or athlexis or having a low pH, or there is a lung volume change and autonomic tone, what happens on the PVR. So we all know normally as zone 1, zone 2, zone 3, and there is a alveolar and arterial difference of the pressures from the up to down because of the vascularity and the gravity. And if the hypovolemia is there, there's a zone 2 also becomes zone 1, whereas zone 3 will become zone 2. So if you apply a PEEP, all will become almost zone 1 because of there is an expand of the zone 2 to, and at the same time expansion of zone 3. But there's a thing you have to keep it in mind, they can be dead space ventilation. So that dead space ventilation is being improved. So in that way, the vascularity and the volume is equivalently moving by adjusting this method. So there is a differential effect on the alveolar and extra-alveolar vessels. What happens if there is alveolar vessels? The alveolar pressure inside the alveoli is outside pressure for the alveolar vessels as it is. So whereas extra-alveolar vessels, that means the outside, it actually have interstitial and pleural pressures as outside pressures. So the difference between the alveolar and pleural pressure is a transpulmonary pressure. So which is actually, we all know that it's important in the ventilatory management and to maintain the patients on pulmonary edema, to maintain the patients on this one, how do we adjust the ventilator? So looking at this, if you see the X and Y, there is a lung volume and there's a pulmonary vascular resistance. Normally, there's a intra-alveolar and extra-alveolar pressures. So as per the volume increasing in the extra-alveolar area, there is a reduction of the pulmonary vascular resistance. And there is increasing the lung volume, the intra-alveolar pressures, there is increasing of the pulmonary vascular resistance. This actually, we can see there's a decrease in transcapillary perfusion pressure, when normally that can actually happen or increase alveolar pressure. And whereas the loss of interstitial elastic recoil and collapse of the vessels and the collapse of the terminal airways via hypoxic pulmonary vasculitis can cause this. So this is actually extra-alveolar pressures. So this will actually increase extra-alveolar pressures, volume, and this one. If you look at the effect of increasing lung volume on venous return, not just the pulmonary vascular resistance, venous return, there is a blood flow and there is a right atrial pressure. There's, as we already told, the venous return is a constant, but when there's increasing the abdominal pressure, so automatically there's a diaphragmatic, because of the diaphragmatic descent, increasing abdominal pressure, increase mean systemic pressure. As we talked about, mean systemic filling pressure or mean systemic pressures are important for the volume or venous return and the intravascular volume maintenance, which will have the effect on the cardiac output. So, airway pressures and intrathoracic pressures. There is an increasing airway resistance, overestimates end expiratory alveolar pressure and underestimates end expiratory alveolar pressure. Sorry for that. So there is increasing airway resistance, which overestimates end inspiratory alveolar pressure and underestimates end expiratory alveolar pressure. So normally a lung compliance, most of the normal lung are pathologically implicated. The pathological lung like ARDS will have a less compliance. So any lung compliance, as you are increasing the volume, there is a decreases intrathoracic pressure, and which actually, if there is a decrease in lung volume, increases intrathoracic pressure. So it's almost opposite direction, and this decrease in ITP will have better venous return, and increasing in ITP will have less venous return. So that will depends on how it is going to affect the lung compliance and the ITP. But remember, chest wall compliance, even though if the tidal volume is constant in the lung, because inside the volume, because it's inside the chamber, like pulmonary vasculature, pulmonary compliance, everything is within the chamber. There is no relation between outside or inside. So that is why even there is a chest wall compliance is reduced, but the increase both airway and ITP, inside pulmonary vascular, there is no change. But as long as the constant tidal volume is there. But if the chest wall compliance is reduced, increases both airway and intrathoracic pressure. So the hemodynamic effects, we all know end expiratory lung volume is increased when the PEEP is being increased, and the end expiratory transpulmonary pressure is increased, and which distance the lung unit proportional to the regional compliance, which actually affects on the hemodynamic effects only if the lung volume increases. Because if the lung volume does not increase because of the PEEP, it's only maintenance the constant, there is no much difference as long as the volume, status, and heart function is good. So whenever you put the patient on mechanical ventilation, if you apply the PEEP, there is an increase in the airway pressure, and which will actually increase the transpulmonary pressure, and which actually increases the PVR, and which increases the RV afterload, which reduces the cardiac output. It has a multiple ways of effect, either by pulmonary overdistension or by increasing the airway pressure, which will increase the cable vein pressure or which will increase the transpulmonary pressure. And also, finally, the end is cardiac output is reduced because of these mechanisms, and which will cause, and indirectly again, as long it's a prolongation. This is how, why when the patient is put on mechanical ventilation, you are trying to wean the patient. At that time, this will cause coronary oxygen delivery reduction that can cause coronary perfusion pressure reduced. So also, if you are not put the patient on mechanical ventilation, because if the hypoxemia, that can cause hypoxemic vasoconstriction, that again cause increase of pulmonary vascular resistance, again can cause cardiac output reduction. So these are the mechanism. That's the reason in hypoxia, putting the patient on mechanical ventilation is good. But if you put the mechanical ventilation, these are the deleterious effects of the mechanical ventilation. Even in 2011, recently, they have studied by almost 42 animals, looking at putting the chest wall compliance tight and making the volume changes in the putting the balloons, that is a pericardial balloon and pleural balloons for 20 post-cardiac surgery individuals, and looked into the changes in the right ventricular stroke volume minus left ventricular stroke volume differences in inspiration and expiration, making the difference of 5 ml to 25 ml, which actually showed at the time of inspiration, there is a heavy fall of the right ventricular to the left ventricular difference of the ml has been shown. But at the expiration, because of the sudden rise and the empty of the volume, that means it shows the volume is important. So intrathoracic blood volume during a positive pressure ventilation, how the dynamic shift have been happened. So that is being shown in this study. So when there is increase in the intrathoracic pressure, differing hemodynamic effects depends on two things. One is ventricular contractility, and second is intravascular volume status. So that is the reason we say that it should be volume status should be taken care seriously. So the stroke volume is nothing but end diastolic volume minus end systolic volume. So which actually decreased preload, decreased end diastolic volume, decreased afterload, decreases end systolic volume. So normally it is a preload dependent, and ventricular failure is afterload dependent. if you see suddenly when you put the patient on ICD of tension pneumothorax, you develop negative pressure pulmonary edema. The pathophysiology of that is there is a airway obstruction, which patients try to inspire forcefully against the obstruction, which actually cause highly negative intrathoracic pressure, which will actually decrease the pulmonary interstitial pressure and acute increase in systemic venous return to the right heart. So because this right heart systemic venous return is increased, there is a pulmonary volume has been increased. When the pulmonary volume is increased, there is increase in pulmonary artery and capillary pressure, which actually the reduction of pulmonary interstitial pressure, increase of the pulmonary arterial capillary pressure, which will have increased transcapillary pressure gradient. So that why the fluid is pushed into the pulmonary capillary interstitial, which will have negative pressure pulmonary edema. This is as a mechanism or pathophysiology of why it happens in interstitial, causing the negative pulmonary pressure pulmonary edema. What will happen when you put the PEEP on the ventilation? But PEEP decreases cardiac output by decreasing LV preload. But as long as the PEEP is minimal, there is no effect much. But you can mitigate this by the volume loading in case when the patient is not having a heart failure. In COPD and sleep apnea, this is how the mechanism. In COPD, there is a broncho-obstruction, and which actually increases intrinsic positive end expected pressure with hyperinflation, which will hampers the venous return, which finally causes pleural pressure during inspiratory attempts, increasing the venous return. So in sleep apnea, again, it actually prevents hypoxemia because the CPAP augments the lung volume, which actually improves the gas exchange, unloads the heart. So this is a benefit, positive effect of the patients putting on a CPAP in sleep apnea patients to improve the tissue oxygenation, increase in the cardiac output. What happens to the RV-LV linked dynamics? Because if you see the space of this, I would like to explain you, even though this is a two LV and RV, the LV is surrounded by the LV is surrounded by the RV with not active myofibrils, whereas the both are shared the same septum, which is more towards the LV. So the LV effect on the RV is more than the RV effect on the LV, except if you see even at the time of pulmonary embolism, there is the RV dilatation, which actually reflects that affects very less to the LV, but whereas LV dysfunction affects the RV more. So LV and RV pump blood in parallel, but are also connected in series. So the myocardial fibrils of the left ventricle most contribute to the septum. RV systolic function depends on this septum. So RV systolic function depends on this. So there's a sudden lusitropic effect of this both biventricular effector, which is at the time of when you want to push or when you want to have a relaxation, because for a diastole time of both, it's supposed to be equal, and that have a RV distension may flatten the septum and decrease the LV compliance only certain extent, but contributing to the LV filling outflow in case of heart failure, but not in a normal conditions, which can compensate. So all these things we know how it is going to be important: lung to the heart to the heart, and vascularity, and the volume, and the PEEP, and the presence of intrapleural, pericardial, and intrathoracic pressures. Looking at this, how do you really going to be bedside beneficial? How we can really take care of it? How we can? It's all by having a less volume, by a less PEEP, and so that there is no change in the volume, because change in the volume is more important than the change in other pressures. And looking at the intrathoracic pressure, how do we can monitor? How do we can take care? So it can be done by card imaging. There's a cardiac loading alterations during changes in ventilation modes and settings, and echocardiography, which is maybe a good method of looking at the heart functions, and by MRI, and also by radionuclide imaging. and the determinations of ventricular volumes by thermodilution. I think previously we used to do a lot of PA catheters, but at the same time, nothing is going to give you directly entire effect of it. It's all how you are going to look at the intravascular volume, intravascular tone, and the effect of the lung volume towards the change between the lung heart interactions. That is the reason why there is no change in the mode of ventilation. Whichever mode you do, either pressure control or volume control, if the volume is constant and there is no difference in the compliance, then there not be any much difference in the cardiac output. But at the same time, looking at the measurement of these heart-lung interactions, yet to get more advanced and to understand. But at the same time, clinically, we can really look at this physiology is going to help us why these interactions are happening, why these pressures, how the pressures are going to alter because of this. So make sure that that's the reason that the lowest tidal volume, you look at the difference between the lung pathology cases of ARDS. In the ARDS, the depends on the, even though if it is heterogeneous lung, in that area, because of this central vascular or alveolar, the vessels collapse, and the pressures are going to be, if it is reflecting on that, and the airway pressures, so that is going to affect. And if the volume is going to increase as long as the compliance has been improved, so there's a reflection of that is not much. So the effect of airway pressures and volumes and cardiac loading and function is complex, because as we told, sometimes even the same patient depends intrathoracic pressure in the respiration. If the pathology is more, it's a negative effect. Otherwise, it's a positive effect. So predominance of effect on cardiac output depends on the underlying function of the heart and pulmonary vasculature. Although the preload effect of increasing airway pressure often predominates in patients, a detrimental rise in right ventricular afterload is unpredictable and should be evaluated in case of severe hemodynamic compromise and absence of fluid responses. A last word just regarding the fluid responsiveness. The fluid responsiveness is, it is just as we told, as long as the unstressed volume is can be changed to too much, it is 70%. At the same time, even if we give the fluid, it is only understand that he can take the fluid. He is fluid responsive. It is not that he requires the fluid. It may compromise, it may deleterious effect even if you give fluid in certain conditions. So that is why it doesn't mean that fluid responsiveness should be means compulsory should give more fluid, because the once that stress volume increases, once you increase the more volume, then the vascular tone or the pressure is increasing, that is caused, that will affect more into the hemodynamic compromise. So thank you. Wait for your questions.
Thank you, sir. Excellent presentation. Hello.
Chappan, sir.
You extensively covered everything, the physiology, pathophysiology, and the effect of positive pressure on lung and heart, both interactions in normal ventilation and in normal heart and failed heart, how it helps in normal heart, how it deleterious effect and how to counteract these side effects. You have covered very thoroughly. My first question is, I completely disagree with one slide that you are showing males are devils and females are angels. Maybe.
I did not say males are devils, just as a.
That image shows.
Actually, అలా చెప్పలేదు సార్, అది మేల్ పెట్టక్కర్లేదు, అది చెప్పక్కర్లేదు, స్టూపిడ్ గా సరదాగా not for.
It shows male face. Just joking. Maybe sometimes correct, sometimes may not be correct, that one. Okay, sir. My one question is, if the patient is a normal patient, if we due to increased afterload and decreased left ventricular end diastolic pressure, decreased cardiac output, if the patient is not responding with fluid, can we start dobutamine to
the effect is to reduce the transmural pressure and improve the afterload and increase the cardiac output. Will it improve the cardiac function in a normal heart with mechanical ventilation, with hypertension?
Yes, sir. So it doesn't have improve in the normal heart, sir. Because in the normal heart, as you said, increasing the afterload, the reason is fluid is, as you said, the fluid is there fully and tone is good and afterload is increased, the reduction of cardiac volume. Am I right?
That is correct, but this
At that
dobutamine
time,
will
all this-
counter this effect. No? Dobutamine.
No. See, the reason for that, is it because of the increased intrathoracic pressure or is it because of the increasing of the volume? Because just by increasing the volume, if you put a dobutamine, how the contracted heart will, because you need to reduce the afterload. Reduce the afterload, dobutamine, see, if you see vasodilatation, that is we know arterial both dilatation, no, sir. So I don't know, because that is actually the cause. You're not treating the cause. You're telling the normal heart.
Yes. Yes,
So
sir. Okay,
you're
sir.
not treating the cause.
Any questions from
Am I right,
audience?
Dr. Varalakshmi?
Yes.
Is she there? I don't know.
It may help in failed heart, but even if it reduce the afterload, but due to increased intrathoracic pressure, venous return, you can't change the venous return.
Because
So
as
cardiac
per my
output will not.
understanding, in the normal heart, it's not supposed to, because not going to affect. But if it is a failed heart, because of requirement of the contraction is less, that may help. I don't know. I think is Varalakshmi online?
Yeah, yes, sir. Can you please repeat the question?
Yeah, I
Varalakshmi?
will ask the question, whether right or wrong, we'll see.
Okay.
See, when you have a normal vascular volume and in the ventilation, Jekina Boyna is also there. In the ventilation, you put the patient, because of increasing the afterload, there's a reduction of cardiac output. If you start dobutamine, it will increase the cardiac output.
Yes, definitely. Dobutamine would increase cardiac output because
In a normal heart.
yes, it does increase. That is what we do in dobutamine stress test and all. No, sir, we will increase cardiac output and see whether patient is tolerating. So even in a patient with normal cardiac status, definitely if it is a euvolemic state and if you give dobutamine, there will be an increase in cardiac output, because rate will increase, cardiac output will definitely increase.
My idea in the normal patient on ventilation, because of the ventilation, there is a reduction, increasing the afterload. So
No.
you are going to force the heart, it's going to cause the failure. So you are supposed to treat the cause. I don't know. I'm just telling.
Sir, they are two entirely different things: dobutamine and mechanical ventilation. Mechanical ventilation in a normal, in a patient with normal cardiac function, the increase in afterload that happens is not significant, because the heart function is good. The patient is able to make those changes required, and the cardiac output will be maintained. In a patient with compromised cardiac status, it may cause adverse effects. But dobutamine is something totally different. Dobutamine, if you give, it will increase cardiac output if your volume status is okay. They are completely different things, sir. Why to combine those two?
Get that?
Combined means Varalakshmi, whether patient
Yes,
is
sir.
on ventilator or it is not the issue. We are using the inotropes, even patient is on ventilator also. My question is,
Sir.
when the positive pressure is increasing the afterload and decreasing the preload and increasing the transmural pressure in a normal heart, the total net effect is to reduce the blood pressure, okay, mean arterial pressure. So,
but yes, sir.
this one you are giving fluid, okay, to improve the blood pressure.
Yes, sir.
When patient is not improving with fluid,
Sir.
then can we start dobutamine to reduce the afterload and reduce the transmural pressure and increase the cardiac output, thereby increasing the blood pressure? So this is my question.
Sir,
It's
so
beneficial.
generally, if the understanding is that if the cardiac status is normal, then that need will not arise, sir, unless the intrathoracic pressure that you're subjecting the patient to is very high. You will not require that kind of a support. If you are requiring dobutamine, then it implies that there is some amount of cardiac dysfunction. That means that the patient's cardiac status is unlikely to be normal.
So
In
it
case
won't,
of
it won't
normal
be
heart function, can we give, Chapani, somebody is telling, sorry.
yes, sir. Any questions from others? Anna, Satish is raising the hand. Satish,
Yeah. Sir, morning, sir.
Morning, sir.
Sir, David question wise, increasing cardiac output is not always equal to increasing the BP. When the BP is the issue, if you want to add dobutamine, it should be a paired heart. Okay. If the BP is not BP, to maintain a good BP with a normal heart, better to go with the vasoconstrictor because dobutamine causes vasodilatation, it promotes the BP. Though there is an increase in the cardiac output, BP also will come down. So perfusion pressure will not be maintained at that point. Okay. So dobutamine will work in a failing heart. Dobutamine will not work in a normal heart because it increases the heart rate rather than increasing the BP. BP will drop because of the vasodilatation, though there is an increase in the cardiac output. In a positive pressure ventilation patient, what we observed is there is definitely reduction in the afterload. Afterload reduction will decrease the left ventricular wall tension, that decreases the left ventricular transmural pressure, whatever the intrathoracic transmural pressure. So ultimately it increases the emptying is very, very easy of the left ventricle. That's how it improves the perfusion and increases the cardiac output. This is what we understood from this lecture. Any corrections in this?
See, the question itself is, he's asking normal heart, normal volume, and
Yes, sir.
decrease because this one can we increase? That's
This
what I
idea is-
understood.
The idea is to
yes, sir.
improve the
What
Sir,
what Satish said is correct only. It increases the cardiac output, but it will not maintain the mean arterial pressure because it reduces the vascular resistance. Peripheral vascular resistance will come down, afterload will come down. BP may not increase, but cardiac output only will increase. Ante kada?
yes.
Due
Sir,
to
the kind
decrease
of
the
response, if I may, the kind of response to dobutamine is that's why we give a trial. We always talk about a dobutamine trial and not dobutamine, sir, because in there are a subset of patients where there is an increase in MAP despite the inodilator property. But in most patients, there is no significant improvement, or there is a further fall in MAP because of the vasodilatation. So generally, people who believe in dobutamine after as a second line, they would start a NORAD, and then if they start dobutamine, they have to start it as a trial. And if there is an improvement in MAP, you can keep continuing because that is good for the patient. If it doesn't happen, then we have to go for other inotropic agents, sir. That's my understanding. Not all patients respond similarly to dobutamine.
Madam, exactly, we don't know in which part of the Frank Starling our heart is at that point of time. So sometimes it will improve with the fluid, sometimes it will
Yes,
improve
exactly.
with the
Exactly. So if it improves, we continue, sir. Otherwise, we will
then
stop.
we can use a pulse pressure variation to
Yes.
see whether patient is preload deficit or preload not required.
Exactly.
Another question, sir. Can we use this electrical impedance imaging technology at the real-time scenario on the bedside to see the aerated lung and hyperperfused or wet lung? All these effects, both cardiac and lung effects, can be monitored with this method. Electrical impedance, images. So both volume status and aeration means lung status with PEEP effects, all these things can be monitored on the bedside and real-time scenario. Can you please add these slides in your talk?
Yeah, this tools to measure HLA, right?
Yes, sir.
Okay, that's
Electrical impedance.
the electrical impedance imaging.
ఇమేజ్ కొన్ని స్లైడ్స్ ఉంటాయి. సో ఇట్ విల్ షో ద ఎఫెక్ట్ ఆఫ్ ది పాజిటివ్ ప్రెజర్ వెంటిలేషన్ అండ్ PEEP in ARDS patients or in LV failure patient pulmonary edema. So that in that case also in real time we can monitor on the bedside.
Okay, I'll ask Varalakshmi because
Last after 1 or 2 you can add.
Sure, sir.
Because
I'll
time
just
is
take
only-
it up once and I'll add it, sir. I'll do it.
అంతే కదమ్మా ఇప్పుడు ఎందుకంటే 20 minutes కదా మరి ఏమన్నా చూడాలి మళ్ళీ టైం కూడా చూడాలి రైట్ ఓకే
అందుకే మీరు ఇనిషియల్ ఫిజియాలజీ in the initial physiology you are taking more time. I think you can because majority of the people knows that some physiology you can cut down in just 2 slides, sir. The net effect, how it affects. Not 10 minutes time for physiology is not required. Just you can cut down into 3 minutes.
Anything Jekina Boyna? Any senior, everybody?
Any questions? Mohan Rao, Jekina, Rani Madam?
Rani Madam?
Srinivas? Hello?
Monanga?
Sir.
Anuradha? Chepma. Chepsino?
లేదు సార్ లేదు నథింగ్ నో క్వశ్చన్స్.
No questions, sir. Only contribution?
సార్ చెప్పండి.
Suggestions కనీసం
సజెషన్స్
అడ్వైజెస్
లేదా అంటే మీ టాక్ 15 minutes 20 minutes తెలియలేదు.
20 minutes అంట.
20 minutes అంటే కొంచెం ఎక్స్టెన్సివ్ గా చెప్పారు కదా 20 minutes సరిపోద్దా లేదా అని.
అదే
ఫస్ట్ ఐ థింక్ ఇనిషియల్ ఇంట్రడక్షన్ లో కొద్దిగా కట్ చేస్తే సరిపోతుందేమో. బట్ వెరీ వెల్ ఎగ్జిక్యూటెడ్ సార్, చాలా బాగుంది డీటెయిల్ గా.
Thanks, Varalakshmi. Rani Madam?
హలో సార్.
చెప్పండి మేడం.
బాగుంది, బాగా కవర్ చేశారు. బట్ ఐ థాట్ వాస్ ఫస్ట్ నార్మల్ రెస్పిరేషన్ లోది బ్రీఫ్ గా చెప్పేస్తే ఈచ్ టైము మళ్ళీ నార్మల్ వెంటిలేషన్ అని రిపిటేషన్ అవసరం లేకుండా ఉంటుంది కదా అనుకున్నా. నార్మల్ వెంటిలేషన్ లో ప్రెషర్స్ అంటే మెకానికల్ లోకి ఆపోజిట్ కదా నార్మల్ రెస్పిరేషన్ లో. అప్పుడు ప్రెషర్ చేంజెస్ వాట్ హ్యాపన్స్ అనేది ఫస్ట్ క్విక్ గా చెప్పేస్తే దెన్ యూ కెన్ గో ఆన్ టు మెకానికల్ వెంటిలేషన్ లో ప్రెషర్స్ కంపేర్ టు నార్మల్ అవన్నీ ఇంకా అండర్ వెంటిలేషన్ ఎలా వస్తుంది చెప్పేయచ్చు. మీరు చాలాసార్లు నార్మల్ వెంటిలేషన్ లో ఇలా ఇందులో ఇలా అని మళ్ళీ కొన్నిసార్లు రిపిటేషన్ అనిపించింది. సో అదొకటి నేను నోటీస్ చేశాను అంతే.
థ్యాంక్ యూ మేడం. జెక్కినా?
Sir, good information, sir. Revision.
Congratulations for becoming medical director, Jekina.
Sir. Thank
Congratulations,
you, sir. Thank you, sir.
కంగ్రాచులేషన్స్ సార్.
Thank you, sir.
Sir, congratulations, sir.
Thank you, madam.
సేమ్ హాస్పిటల్ సార్?
లేదు డిఫరెంట్ హాస్పిటల్ సార్.
మరి అది అనౌన్స్ చేయాలి కదా సార్ మోహన్ సార్.
నెక్స్ట్ ఏంటి?
శ్రీనివాస్, కంగ్రాచులేషన్స్. ఏ హాస్పిటల్?
ఇది అమూర్ హాస్పిటల్ అని ఉంది మేడం, ఇక్కడ కుకట్పల్లి వై జంక్షన్ లో.
అమ్మోరా
హాస్పిటల్
అమ్మోర్ హాస్పిటల్
స్పెషాలిటీ హాస్పిటల్.
సరే ఎలివేటెడ్
అమర్రా
250 బెడెడ్
హాస్పిటల్ కుకట్పల్లి వై జంక్షన్ లో ఉంది. న్యూ
మీకు తెలుసా
హాస్పిటల్
మేడం అమర్ హాస్పిటల్?
తెలీదు సార్.
సో ఇది మన సతీష్ సార్కి తెలుసు అంతే. ఎవరికి తెలీదు. మోహన్ సార్ మీరు వచ్చారా? మీరు రాలేదు కదా?
లేదు సార్, ఇంకా మమ్మల్ని పిలవలేదు మీరు.
అన్నా
సార్
శాంతి
నేను చూసా హాస్పిటల్. మా మేనర్కి యాక్సిడెంట్ అయితే అక్కడ అడ్మిట్ చేశారు.
అచ్చా అచ్చా. ఈ ఆర్టీఏ బాగా వస్తాయి సార్, ఆల్మోస్ట్ డైలీ 2 RTAs వస్తాయి ఇక్కడ.
Srikanth is a very good
Accident
speaker. He should give suggestion.
సార్ సార్ అదే కొంచెం ఎక్స్టెన్సివ్ గా ఉంది సార్. చిన్న అంటే వాయిస్ మాడ్యులేషన్స్ ఉంటే బెటర్ గా ఉండేది అనిపించింది సార్, అంతే. అంటే కొంచెం ఫ్లాట్ గా వెళ్ళిపోయింది మొత్తం అంతా. సో చిన్న అంటే ఇంపార్టెంట్ దగ్గర అక్కడ చిన్న వాయిస్ మాడ్యులేషన్స్ అవి స్ట్రెస్ చేసి అలాగా, అంటే వాట్ యూ ఫెల్ట్ ఇంపార్టెంట్ అన్నవి కొంచెం స్ట్రెస్ చేసి చెప్పు. బట్ అంతే సార్, అంత మించి మిగిలిన స్లైడ్స్ అవన్నీ కూడా చాలా బాగున్నాయి సార్. టాక్ టైం కి కన్సెస్ చేసుకుంటే సరిపోతుంది సార్. వాట్ ఐ ఫెల్ట్.
Anything else?
Okay, sir.
Thank
Any
you.
questions?
Thank you, Lakshman. Thank you all. And congratulations, Srinivas.
Thank you, sir, for nice presentation. We will close the session, and next week, Care Hospital is going to have a webinar on Thursday. Thank you.